Hello and welcome everyone. I want to welcome you to the Dementia Care Aware March webinar. We're going to get started here on time today so that we have the full hour together. I know many people are still signing on, so I'll do this introduction a little bit slowly. So this is our March webinar for Dementia Care Aware. We're a program of the Department of Healthcare Services and very proud to be. This is a great topic today, adapting the cognitive health assessment for patients with substance use disorder and serious mental illness. And our presenters are Dr. Christine Soran and Triveni Defries. And I'm your moderator, Anna Chodos. Next slide. Just want to introduce you to our speakers briefly. I'm over here on the right, and I'm serving as the Executive Director of Dementia Care Aware. Once again, very proud to do so. And I'm incredibly honored to welcome my colleagues, Christine Soran and Triveni Defries. They are my colleagues here at UCSF and at the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital. Dr. Soran is a primary care and addiction medicine clinician and the medical director of an outpatient buprenorphine induction clinic. Dr. Defries is also a primary care and addiction medicine clinician and works on our National Clinician Consultation Center Substance Use Warm Line. Next slide, please. None of us have any financial disclosures to make today. Next slide. And I always start out our webinars with a brief overview of our program. Dementia Care Aware is a statewide program, and we're very proud to offer several services to help providers and primary care do dementia screening and support their patients and their healthcare teams. First of all, we launched a warm line just this month. This is an 800 number that we'll put at the end as well. So you're welcome to write it down. It's on our website, dementiacareaware.org. And we provide real-time support for clinicians doing dementia care. We actually answer all phone calls, but we have expert consultants there to answer questions about dementia screening and care. We have ongoing trainings. We have future online modules coming up on all topics of dementia. We have mostly our cognitive health assessment training as our centerpiece. We have monthly webinars, as you well know, and we have a Dementia Care on Air podcast with another episode coming out shortly. We have our first one up on many streaming platforms. We have ECHO conferences, which are interactive case-based conferences to learn how to do dementia care and screening. And then if you're a clinic or an administrator, we'd love to talk to you about our practice change support resources, the Alzheimer's and Dementia Care Program, which is through UCLA, and the Alzheimer's Association's Health System Support Program that helps do practice improvement with practices. Next slide, please. Again, if you go to our website, you can get CME and do our online training to learn about the cognitive health assessment. Next slide. And really briefly, as we launch into this webinar today and really focus on the issue of substance use disorder and some aspects of serious mental illness and the cognitive health assessment, we always like to start with a brief reminder of what the cognitive health assessment is, knowing that many people haven't had the time to learn about it yet. This is a screening tool, and the tool we put out there is adapted and thought through for using validated tools for our Medi-Cal patients. But we really recommend it as a screening tool for folks 65 and older as an annual screen. And the main components are first to take a patient history, which many of us already do. Many of our patients go through a quick screening process in clinic, a quick question about if they've noticed any changes over the last year, for example. Then use validated tools to understand how that person might be doing with regards to cognition and function. And then finally, to ask about the person's care partner. If you take the training and look at our tools online, you will learn how to do the cognitive health assessment and interpret it and document it so that you can take advantage of the new Medi-Cal benefit to bill for this, as well as other benefits. And if your patient is a Medicare patient, for example, through annual wellness visit screening options. And we really like to emphasize, and you're going to hear a lot about this today, that it allows you to start a brain health plan at the earliest detection of any cognitive symptoms. Next slide, please. And so I'm honored to transition us into the meat of our webinar today. Our learning objectives are that by the end of this webinar, you'll be able to identify the impact of substance use on people with cognitive impairment, incorporate a workup for substance use and serious mental illness in an adult with cognitive impairment during screening and next steps, incorporate care of substance use disorder in your brain health plan, and adapt substance use disorder treatment for people with cognitive impairment. And I just want to point out, as you can tell by our experts today, we're really focusing on the aspects having to do with substance use disorder. And we will have a whole other webinar upcoming on serious mental illness as well. And we're just going to touch on it briefly throughout today's webinar. So I'd love to turn it over to Dr. Defries to continue the learning. Thank you, Dr. Defries.
Excellent. So we'll start right here by reviewing a little bit of background in epidemiology to help us understand the problem we'll be discussing today. So why is it important that we're talking about assessing unhealthy substance use among people with cognitive disorders? Well, a lot of what we know about this comes from data about older adults in the US. And we now have the largest group of older people in history in the US. And as they age, more presentations and complications of substance use are going to be seen. And substance use disorder is on the rise in this rapidly aging population, and it's projected to increase. And this might be due to several factors: aging of the baby boomer generation, for example, who may have changing attitudes towards substance use, and then those who are more likely to use substances when they were younger continue into later life. And as people age, they're more likely to have negative effects of drugs and alcohol from their comorbidities or interacting medications. And most people over 65, they don't use illegal drugs, but almost 20% of older adults misuse alcohol, over-the-counter medicines, and prescription drugs, often unintentionally. And most commonly, alcohol is the substance that's used more than anything else. For older adults, data does show that harms of this substance use are on the rise in the form of hospital admissions, and as this graph shows on the right, in overdose rates. And we know that substance use impacts people from all backgrounds, but we see these harms disproportionately affect people of color and people from minoritized backgrounds.
So now that we've reviewed that substance use is on the rise, let's talk more about how substances affect the brain. So we know that in the acute setting, when someone's using drugs or alcohol, that they feel acute intoxication. Next slide, please. And in that setting, they have impaired judgment, inhibition behavior, impaired memory and attention. And with time, our brain adapts to that to that acute intoxication state. And with that comes changes in metabolism, microvascular changes, receptor downregulation, our neurons communicate differently, and even epigenetic changes. And with chronic use over time, there are effects on cognitive domains, executive function, memory, and attention. But what do we actually know? Do drugs and alcohol cause dementia? Do they cause cognitive impairment? Most of our research comes from alcohol. We do know alcohol negatively impacts memory and can increase the risk of dementia. In particular, heavy drinking is associated with higher rates of cognitive problems and Alzheimer's dementia. Light to moderate drinking can increase the risk of mild cognitive impairment changing into dementia over time. And if someone is having cognitive challenges and they continue to drink, it can worsen dementia symptoms. If someone's using benzodiazepines, they're at a higher risk of developing dementia as compared to people who never used benzodiazepines. For current smokers, they're at higher risk of developing dementia as compared to former or never smokers. And for other substances such as stimulants or opioids, we have less information and less data about if they cause dementia or dementia syndromes. We do know, though, if someone's cognitively impaired, it may impact their ability to use substance safely. And in the acute setting, we know that older adults are at higher risk of negative effects. So if someone is using a substance and is also on a medication that may interact or may be at risk of falls and they're acutely intoxicated, that they could have more harm in the acute setting, in addition to developing some of these long-term changes in their cognition. So as we've reviewed how drugs and alcohol impact the brain, let's talk more about how we incorporate this information into our assessment.
I'm coming back on just to briefly review the cognitive health assessment again, because really what this webinar is helping us to understand is how we can think about the impact of substance use disorder and serious mental illness more broadly on the whole workup. But if we think specifically about the cognitive health assessment, the approach in someone with substance use disorder, I think the main point is you can still use it. It's still a valid screening approach. Again, that components being asking a question, a brief patient history, using screening tools, and documenting care partner information. Next slide, please. And if you've taken the training, you know this, and if not, this is a new information, but the way we talk about taking patient history in a screening moment is really to have a brief question, perhaps that a non-primary care provider member of the team gets to do as part of other screening efforts, like, have you noticed any changes in the last year to your thinking or memory? Next slide. And then when we talk about screening tools, we talk about tools for cognitive and functional assessment that can be given to the person or the informant. Next slide. And in our materials, you'll find the recommended tools and also links to find those tools and some information on how to use them. And here you could still use the tools we recommend, the GP-Cog, the mini-Cog, for the patient for a cognitive assessment, or the 88 or short IQ code for that to the care partner. And for function, we recommend an overview, sort of a checklist of ADLs and IADLs, or a tool given to an informant. And often with our patients, if we suspect cognitive and functional decline, we want that informant information. And this may be another opportunity if someone has substance use disorder, and that's a big component of their history, and active medical plan that you're working with them on, to consider getting additional care partner input into what the symptoms and assessment are, particularly if that person's there. And often people don't have an informant, but if they do, it can be really valuable to get that information. Next slide. And finally, the care partner information, we recommend doing this up front, and that would be true for any patient, kind of regardless of the other medical context. And now back to my colleagues.
Okay, thanks, Anna. So let's go ahead and start with a case. And this is a case that we're going to explore actually for the rest of the webinar. This is Jesse. He's a 72-year-old patient who presents to your primary care visit with his adult daughter caregiver to follow up on memory and cognitive challenges. And at your last visit, you assessed his cognition and his function. And today they're here for further assessment. So older adults like Jesse, when they experience unhealthy use of substances, they are usually under-identified, underdiagnosed, and undertreated. And experts have called them an invisible population, even though they may be having more frequent healthcare visits. So what makes it so challenging to recognize substance use problems in older adults? Well, many people think that substance use is just a young person's problem. Stereotypes and bias about older adults or about people with addiction or mental illness are common and may make it hard to talk about. Stigma and shame are very common barriers to addiction treatment, and some older adults may have grown up in a time when substance use and mental illness received a great deal of stigma. Older adults are also less likely to seek care in traditional addiction treatment settings, and they may be harder to diagnose with substance use issues because of cognitive impairment, functional impairment, or other medical conditions that may obscure or overlap with signs of harmful substance use. And clinicians can face difficulty applying diagnostic tools to this population, and also with how to engage caregivers. And lastly, they may face barriers of time or lack of knowledge about substance use disorder management. So hopefully we can help address some of these today. Patients are going to present with unhealthy substance use in different ways. Some may present via screening, some with signs and symptoms, and some through concerns of caregivers or other providers. And the goal is that there is no wrong door to address substance use. This does not have to be done in a specialty addiction treatment setting or by a specialist. And we hope to equip you with some skills today to help, because primary care is a great place for diagnosis and care of substance use disorders. So substance use occurs on a spectrum that spans from abstinence to riskier use, all the way to substance use disorder on the top here, where people have a problematic pattern of behaviors that leads to negative life consequences. And these are defined by the DSM-5 criteria. So as consumption increases, consequences of that use generally become more severe. And for older people or a person with a cognitive disorder, consider how things might shift on the spectrum. The same levels of use, even at low levels, may be riskier. They may have more consequences. And actually, most older adults who misuse substances won't meet the full DSM-5 criteria for a specific substance use disorder, but may be engaging in risky use of substances. So consider how substance use may change over an individual's life course, and how you cannot assess or screen a patient just once in their life, but really need to rescreen and reassess at any age. So screening detects patients that have substance use that lies in that riskier or unhealthy use part of the spectrum, theoretically to catch disease earlier and prevent progression to more severe use disorder. And for people who feel uncomfortable discussing the topic of substance use, screening can actually help open the conversation. So when you're doing a cognitive health assessment, you could integrate a screener as one option to start the substance use assessment. And I say this is an option because it may work better for some patients rather than others. Some people may have limited vision, writing, or cognition to be able to fill out a form. And then be aware that there are few validated approaches that are specifically designed to screen older adults for substance use disorders. So typical screening tools may have limitations in this population. There are no validated screeners, for example, for prescription or over-the-counter medication misuse or other drugs in this population. So usually a more holistic assessment's needed, and we're going to demonstrate that for you today. And it's also important to include input from caregivers into this process. So here on this slide is an example of a validated approach, actually, that we can use to screen an older adult for unhealthy alcohol use. And you can start with the question, during the past 3 months, have you had anything to drink that has alcohol in it? And if yes, go on to use a tool like the Audit or Short Michigan Alcoholism Screening Scale to see if someone will benefit from more intervention and referral to treatment. One major limitation of screening approaches is that there's no known safer drinking limit in patients with cognitive disorders. The US guidelines that you see here in the blue chart, as well as the Audit C screening tool on the other side, are commonly used, and they're based on quantities of alcohol that are not adjusted for patients with dementia. So US guidelines recommend the following drinking limits, and adults over 65 fall into the same category as women here, where no more than 3 drinks a day and no more than 7 drinks per week are recommended. And drinking over these limits has been found to be associated with health problems like increased risk of cancer, for example. But for those with dementia, even 1 or 2 drinks may not be safe. So these guidelines really need to be contextualized to the individual. And the recommendation for people with cognitive disorders is that the safest level of alcohol use is none at all. So one tip that can help you to contextualize is to discuss standard drink amounts with your patient. And here are the different types of alcohol. And each drink here represents 1 US standard drink, which has the equivalent of 14 grams of alcohol. So using this diagram with your patient and really quantifying amounts can be a good assessment and counseling tool. But relying on an older adult patient's history and report of the frequency and quantity of their substance use isn't really a full indicator or give you the full picture of the actual consequences of that use. So here's the Short Michigan Alcoholism Screening Test, geriatric version. And it's the first brief alcohol misuse screener developed for older adults. And if a client marks 2 or more of these items as yes, it suggests a potential alcohol misuse. And this tool has more geriatric focused questions, which is what I want to point out. For example, it includes questions like, when you feel lonely, does having a drink help? And have you ever increased your drinking after experiencing a loss in your life? So it's designed for a population that drinks less heavily and isn't based on just how much they drink, but how alcohol is having a role at a stage in their life where their roles and function are different. Older adults with substance use disorder are often underdiagnosed, in part because the DSM-5 criteria does not always capture well in older adults. So the DSM-5 criteria are used to make a substance use disorder diagnosis in the general population. But as I said, not all the criteria apply well to older adults. For example, tolerance, or the need to use increasing amounts of a substance to obtain effects, is a key diagnostic criterion. But because of the natural aging process, older adults have a lower tolerance for alcohol and other substances, and they may experience harmful effects at lower amounts of consumption. So tolerance in an older individual does not necessarily translate to being dependent on the substance. Another example is the criterion of failing to fulfill major duties at work, which will not necessarily apply to an older adult who's retired. So keep in mind that these DSM-5 criteria are an important guide, but they should be interpreted in an age-appropriate manner. So how will substance use disorder in an older patient with cognitive impairment actually present? So it's really important to understand the patient's physical health and overall well-being, because signs of substance use disorder might be mistaken for or overlap with those symptoms of a co-occurring medical or mental health disorder or a natural aging process. So this includes common conditions that we see, like sleep problems, chronic pain, difficulty with ADLs, falls, new or exacerbated cognitive impairment, hypertension, or depression. So let's return to Jesse's presentation. Jesse is most bothered by problems with sleep and chronic pain. He does not like taking medications for hypertension. Life has been hard after the death of his spouse. His daughter has noticed that he's more withdrawn, isolated, and confused recently, and she worries that he only leaves the house to purchase alcohol. And you do some further chart review and see that he actually had a positive substance use screen from several years ago. So our job here is not to diagnose if a substance use disorder is the single cause of Jesse's cognitive impairment, but to really assess how it's playing a role in his life, function, and cognition. And a full assessment of this might not happen in just one visit, but might come out over time, maybe over several visits. And the assessment first involves approaching the topic from the perspective of concern and curiosity about somebody's overall health, not just their substance use itself, and asking permission before broaching the topic. Then you want to characterize not just what substances someone uses, but how they use. That means when, how often, with whom, what routes of administration do they use, and what has happened in the past if they've stopped using, used too much, or mixed more than one substance. Contextualize how substance use fits into their life by asking, what do you like about using alcohol? What does it do for you? What concerns do you have about your alcohol use, if any? In what ways would your life be different if you weren't using alcohol? How has alcohol affected your relationships? And then lastly, understand their treatment history and what their goals are for change, if any. Have you ever tried stopping or cutting back in the past? What was that like for you? What helped? What are your goals now for your alcohol use? Part of your assessment should include screening for co-occurring mental health disorders, because we know that depression, anxiety, PTSD, and other disorders so commonly co-occur with substance use disorders. And their symptoms can overlap with substance misuse and cognitive impairment too, and can make substance misuse worse if left untreated. And I'm going to hand it over to Anna now to tell us more about screening for mental illness.
Yeah, thank you. And just to acknowledge to the audience, one reason we really wanted to keep some of this in this webinar is this co-occurring issue, and the fact that if we're detecting some symptoms and decline on this in the screening moments, that we're going to incorporate an assessment for both things, substance use disorder and mental health disorders, symptoms, serious mental illness, in the next steps process. Again, I'm also coming back to do a little bit of a plug for our May webinar. We're still settling on a date, but that will focus and do the deeper dive on serious mental illness and overlap with cognitive disorders and how we assess and treat. But here in this context, knowing that these often co-occur, I also want you all to be aware that in the screening moment in the cognitive health assessment, you can still proceed the same way and do the screen the same way. And it's when it's positive that we've noticed the person has symptoms, they have a positive screen in either cognition or function. And so we decide to do a next steps evaluation. When it comes to the mental health issues, what are we going to use? Well, in older adults, we often assess for the presence of common mental health conditions like depression, anxiety, and PTSD with screens, some of which are validated in older adults. And the ones that I've seen most recommended are the geriatric depression screen, which has many different versions with different number items, 5, 15, or 30. But often in primary care, it's a little more feasible to do the 5 item or the 15. The PHQ-9 is validated in older adults, and that's one that I know is incorporated in many, many primary care settings already. The GAD-7 for generalized anxiety symptoms. And in PTSD, repeatedly, the Veterans Administration is a wonderful resource for PTSD assessment and care planning. And there are many validated screens in older adults, fortunately. But one simple one you might look into is the primary care PTSD screen. Next slide. And we also know that serious mental illness and cognitive disorders overlap. And this is a very small preview of what you'll learn in a future webinar. But we know that serious mental illness that's affecting daily functioning can also have serious cognitive symptoms. And often those symptoms are present more often when the person has negative cognitive symptoms like psychomotor slowing and reduced affect and things like that. We also know that attention, memory, and executive function as cognitive domains are more often affected and either reported symptoms or sort of objectively noticed. And so it can really look like serious cognitive symptoms consistent with a neurodegenerative disorder like Alzheimer's. And it's only when we do this digging and this additional assessment that we find that the person maybe has a mental health disorder contributing. But just like we're talking about with substance use disorder, an individual assessment of the person's overall picture with regard to their cognitive symptoms, their ongoing strengths and retained abilities will help just with the practical, aspects of making a care plan and really thinking through in this context with these symptoms, whether they meet criteria for a mental health diagnosis or not, what support would make sense? What kind of strategies would I use to support this person? For example, if someone has memory challenges and attentional challenges, do I give them different kinds of information, more information to help them retain some of what we discussed today and what we're working on with the care plan? So thank you so much, and I'll pass it back to Dr. Defries.
Okay, excellent. So whether you're discussing mental health or substance use with a patient, it's really important to take a non-stigmatizing and non-judgmental approach. And just like with younger adults, these kinds of techniques and motivational interviewing strategies are important with older adults as well. So building a welcoming, respectful environment and ensuring privacy, which includes asking permission before discussing substance use with patients and their caregivers, is an important tip. You can normalize that you talk to all of your patients about this because substance use affects their overall health, showing empathy and concern rather than judgment and bias. You can use open-ended questions and statements that start with tell, explain, describe to me, or what and how, rather than closed yes/no questions. And use clinically accurate and non-stigmatizing terminology that's person first. We've been trying to model that through this presentation using terms like substance use disorder instead of substance abuse and person with a substance use disorder rather than addict or alcoholic, for example. So let's talk to Jessie more about their substance use and try to demonstrate some of these principles. We're going to do a quick role play, and I'm going to play the role of clinician, and Dr. Soran is going to play our patient, Jessie. So here we go. Jessie, at your last visit, we talked about your memory and thinking, and I want to talk about some other things that can impact your thinking. Some of these things are kind of personal. Is it okay if we talk about this together with your daughter here, or would you prefer that we spend some time one-on-one?
Sure, she can stay.
Okay, that sounds good. I'm going to ask some questions directly to you, and then your daughter will have the chance to add anything she'd like at the end. Is it okay if we talk about drinking or even other drugs?
Yeah, I guess that's okay.
I've noticed that for a lot of my patients, they use alcohol or drugs, and it starts to impact their memory as they get older. Tell me about your drinking.
Well, I've always been a drinker. It's never been too bad though. And I got by, it never affected my job. It wasn't a big deal. I did start drinking more after my spouse died last year, and I was drinking every night, but I cut back recently, and it's more like every other night when I'm bored or on my own. And then I go to game night with a few friends and have a few drinks there.
So when you say you're drinking, tell me about what it is that you're drinking. Like, what do you like to drink and how much?
Yeah, it's mostly red wine, a couple of glasses here and there. And like I said, though, I've cut back, and I guess sometimes I might finish a bottle or two on my own once or twice a week and forget to eat dinner those nights. But I'm not driving. It's not like I have anywhere to be. And then the pours can be kind of big at game night too.
Your daughter sent me a message last week and told me that she called you at night and you were slurring your words, and then you didn't remember the conversation the next day. She was pretty scared that you were going to fall or hurt yourself.
I don't even remember talking to her, but I know I haven't fallen. That's never happened.
Okay. Well, thank you for sharing all this information. Can I summarize what I just heard?
Yeah, of course.
Okay. So you saw the need to cut back on your drinking recently, but you drink more when you're alone, when you're lonely, and then you sometimes have trouble remembering the night before. And you're here because you're trying to keep your brain as healthy as possible. Do I have that right?
Yeah, that's right. And my daughter, I see she's nodding and she clearly agrees. And I think she's concerned too.
Is it okay if I give you both some more information about how alcohol might be affecting your brain and your health?
Yeah, I'm definitely worried about my memory. I want to hear more.
Yeah. Well, even though you've cut back, you might notice that your body's reaction to alcohol is different than it used to be. And alcohol can make memory and thinking worse and can even cause or worsen dementia. It might even be contributing to some of your sleep problems and pain and even the high blood pressure. So what you've been describing to me today in our visit is similar to people who may be having a problem with alcohol. So we should keep checking in about your drinking and keep a close eye on any new medications that you might start that could interact with alcohol too. And since your memory problems have been affecting your daily life lately, we recommend not drinking at all. That's something I'm happy to support you on. Okay, we'll stop the scene there. And hopefully that brief role play helped to highlight just a few practices that included asking the patient's perspective, reflecting back the patient's own words to them, and providing some education, and then really keeping the door open for follow-up discussions.
So now that you've spoken with your patient and assessed their substance use, let's talk a little bit more about how you incorporate that into the plan. So first, I'm going to outline 4 different points about how to incorporate that into the plan. The first is having a non-judgmental conversation in universal education. Next is discussing harm reduction. Third is offering treatment. And the fourth is having an increased emphasis on other aspects of the brain health plan, including reviewing medications, talking about social networks, and involving the caregiver. So first, we recommend providing universal education on substance use and the effects of it on the brain to all patients and caregivers, regardless of if they have unhealthy substance use or not. So one way to do that would be, Jesse, can I share some more information about the impact of alcohol on the health of the brain and memory? Most often people say yes, and then you can go in to share more information about that. We do know, as Dr. Defries highlighted earlier, that if someone's already having cognitive challenges and they're using a substance, that there likely is no safer use limit. And so the best recommendation is to stop completely, recognizing that's not for everyone and less is better. So if that's not someone's goal, even starting with recommending cutting back to the safer drinking limits for adults over age 65 can be one recommendation. Next slide, please. The second step to addressing substance use in your brain health plan is talking more about harm reduction. So what is harm reduction? Harm reduction really is a set of practices and principles focused on reducing the harm of substance use and improving overall quality of life. Our goal should not be to convince people to stop using drugs or to be completely abstinent, and recognize not everyone in that moment is going to want to talk about it, and that's okay. We need to approach this with non-judgment. Some general best practices when thinking about reducing the harm of drugs or alcohol in someone who has cognitive challenges includes, if someone's not wanting to stop completely, less is better, and even small decreases in use can have a great impact. We recommend using in the presence of others. So in the acute intoxication state, if someone's potentially at risk of falling, becoming oversedated, or even having an overdose, there are other people around who can support and help in that scenario. We also recommend making sure people are getting adequate food, hydration, both to prevent dehydration and to reduce some of the metabolism of that substance so they have less of those acute intoxicating effects and less risk of malnutrition and vitamin deficiencies later on. We recommend people plan time for sleep, including time coming off of a substance so they can get adequate sleep. And then using in a setting where they can reduce their physical injuries. So focusing on falls prevention, not driving. And then lastly, we recommend all people who are using prescribed substances that they have naloxone and their caregiver has naloxone and that they know how to use it to prevent the risk of fatal overdose. These are some basic practices. I recommend checking out the National Harm Reduction Coalition for more specifics, including more specifics by substance. The next part of approaching substance use for your brain health plan is offering treatment. We know that treatment in older adults is both effective and desired. We know that older adults also experience significant barriers to treatment, and that interventions need to be adapted to the individual needs. And we're going to highlight a few of those in particular, focusing on changes that you may make for someone who is having cognitive impairment. Treatment can include medications, behavioral interventions, and harm reduction, as we just talked about. And there should be no wrong door for treatment. We all can do this in primary care, and it's one step to making sure people get adequate care for their brain health. So I'm going to start first by focusing on evidence-based medications for alcohol use disorder. And the big takeaway here is that medications are effective and really should be considered for all patients. They can reduce heavy drinking days, reduce cravings, and increase rates of abstinence. I outlined here a few considerations you might want to take into account for someone who is also having cognitive impairment, focused on side effects and dosing. And a few things to highlight is that naltrexone is very effective and generally well tolerated. And then disulfiram is generally not recommended for individuals with cognitive impairment, given they may not remember to take it. It's only effective if taken, and then later on may not remember what effects to expect if they do drink. The big takeaway for medications for alcohol use disorder are naltrexone should be first line, given its effectiveness and side effect profile, and other medications should be considered, given they can provide benefit and if they outweigh the risks. One other point related to alcohol use is we do need to consider the risk of alcohol withdrawal, and we know that alcohol withdrawal can be more complicated in older individuals and older individuals with cognitive impairment, and many people who have an alcohol use disorder and plan to stop completely could be at risk of complicated withdrawal and would benefit from an inpatient medically supervised withdrawal management program. If this is a scenario, we really recommend getting help from your local specialist to support them in that withdrawal management plan. Next, moving on to evidence-based medications for opioid use disorder. Again, I want to highlight that these medications are effective. They reduce all-cause mortality by 50%, reduce unprescribed opioid use, reduce the risk of acquiring infectious diseases, and so really should be considered for all patients who do have an opioid use disorder. The two main medications we think about are methadone and buprenorphine. Methadone certainly is something that is safe and effective when provided in an opioid treatment program, which is the only setting people can receive this treatment in, recognizing that the clinicians there need to take into account drug-drug interactions, sedating side effects, and the individual's comorbidities. And then I want to highlight that buprenorphine is something that is generally well tolerated in older adults and even those with cognitive impairment, and is something you can provide in primary care. So really considering how you might start that at a lower dose and slowly up-titrate that for a patient who's interested. The big takeaways, though, for medications for opioid use disorder is that it's highly effective. It should be offered to all patients, regardless of cognitive status, given the significant benefit, particularly related to mortality. The medication dose depends on that individual's desires and comorbidities. Buprenorphine may be the preferable option, given its more favorable side effect profile. And next, thinking about medications for other substance use disorders, we know there are no FDA-approved medications. For someone using stimulants, there's been some early evidence that mirtazapine or bupropion with injectable naltrexone had been effective. So you may consider these medications, especially if someone has co-occurring depression or anxiety. For benzodiazepine use disorder, we recommend really focusing on wraparound support for that individual's co-occurring anxiety or insomnia, and then also taking into account the risk of withdrawal, as you would similarly to individuals who are using alcohol. And then for cannabis use disorder, there are no FDA-approved medications. And we know treatment is not just about medications and harm reduction. There's also behavioral interventions. These need to be adapted to the individual's needs. And everyone is going to have unique needs. Some may need adaptations, others may not. And we also need to respect differences in values and backgrounds and preferences. So things to consider is that would someone benefit from a group setting versus an individual setting? And can they participate in a group? Is the group relevant to their life experiences? Is this someone who would prefer to be in person versus telehealth or home visits where that's available? And some adaptations to consider include going at a slower pace, more repetition and shorter session length, adapting program materials to that individual's learning style, including large print format, visuals, audio recordings, and considering other adaptations as needed for people's visual, hearing, or physical needs. We also recommend thinking about age-specific peer support programs, which can be more beneficial for older individuals. They often talk about relevant topics like grief and loneliness and life changes, and just being around peers who understand that individual's current experiences as an older adult. One example of this is Seniors in Sobriety. It's similar to an AA model, but focused on seniors. Next slide, please. Next slide, please. Excellent. And then lastly, I want to touch base briefly on how substance use will enhance your focus on other aspects on your brain health plan, in particular medications, thinking about someone's social network, and caregiver involvement. So first, thinking about medications, we know in someone with cognitive impairment who's older, all of you are going to focus on deprescribing, and this becomes increasingly important if someone's using a substance that may interact with those medications. I'm only going to briefly touch on prescription medication misuse, because this will be highlighted in other aspects of the Dementia Care Aware curriculum, but a few key points are, if you are thinking about stopping or tapering a prescribed substance, such as a benzodiazepine or opioid, you need to weigh the risks of stopping and tapering with the risks of continuing, and trying, unless there's imminent safety concerns, really trying to get the individual's buy-in while you build up other supports and treatment options. Next, we're going to talk about how individuals' social networks and isolation may impact their substance use. We know that social networks can be both positive and negative impactors on substance use. So someone's social interaction may all revolve around substances. There may be drinking in retirement communities where it's served at every meal. We also know that social networks can be a positive area for change. And in particular, if we think about ways to combat isolation, which can drive substance use in older adults. One example may be focusing on mutual aid support groups, where people can get this social interaction with others with similar challenges. And lastly, my last point I want to focus on is involving caregivers. This is incredibly important to all aspects of care for older individuals and those experiencing cognitive challenges. For substance use in particular, we want to emphasize always asking permission, knowing substance use is particularly personal. And then one key thing is trying to assess the caregiver's role in the individual's substance use. It's possible that caregiver is using drugs or alcohol with the person they're providing care, or may even be giving them substances to help sedate them or help with behavioral challenges, or may feel some guilt or shame about talking about it or providing substances for the individual. So really, as much as you can, in a non-judgmental way, including that caregiver in your conversations about substance use. And then including the caregiver on the treatment plan without placing the burden on them, and making sure caregivers have support for their own mental health and social needs. Next slide. So let's come back to Jesse. So as a reminder, Jesse's our 72-year-old patient with cognitive changes. And at your last visit, you assessed his substance use and you determined he does meet criteria for an alcohol use disorder. We're going to role play again how we might talk with Jesse a little bit more. And again, Dr. Defries will be the clinician and I'll be Jesse.
Jesse, it's good to see you back today. Is it okay if we talk more about your drinking?
Oh yeah, I've been trying to cut back. It hasn't really been going well. I think I need help. My daughter's here again, and I know she agrees, and I don't want this to feel like it's all on her.
Got it. Thanks for sharing that. And do you want to talk more about different treatment options now?
Do you mean pills? Are they safe?
Good question. We do have good treatment options, including medications, to help people cut back or stop drinking. And there's also counseling supports. Are you interested in learning more about either of those?
Are you talking about AA? I really can't hear well in groups. It's already hard for me to get out of my apartment, and I don't want to be in a group of a bunch of young people.
AA is one option. It's not for everybody. There are programs for people who have similar concerns as you, like people who've lost a spouse or feeling lonely, or people who are seniors.
I don't want to be in a program. You said medications. Are they safe? I already take a lot of pills, but I guess I could take one more if you recommend it.
Yeah, the medication I would recommend for you is called naltrexone. It's safe with your medical conditions and other medications that you take. I've checked those over, and it doesn't cause any harm if you take it while you drink.
I guess I could take a pill. So some people still drink while on this medicine. I really do want to stop. I think it'd be good for my thinking, but just in case I have a drink or two at game night.
You have a pretty clear goal.
I think I could do it when I'm on my own. It's better for me not to drink alone, and that's okay.
That's a great point. Drinking when other people are around is usually safer too.
I see my daughter shaking her head, and she also told me she's going to start visiting every Monday and might call me more often at dinner because she knows that's when I get a little bit more lonely.
A lot of healthy ideas here. Can I summarize the plan?
Yeah.
You're going to start taking naltrexone, and your goal is not to drink alone. Your daughter is going to support you in this plan by visiting and calling you regularly, especially during dinner time. So we've talked about a lot, and I'll give you a summary of what we talked about so you can reference it later. I could record a voice memo or write it out or give a copy to your daughter too, whatever works best for you. So let's follow up in about a month to check on this plan, and if either of you want to talk more about getting more support or resources.
Excellent. Thank you. And so we're going to move on to some key points, and then we'll have time for some question and answers. So some key takeaways from our presentation today are, after you have a positive cognitive health assessment, follow-up assessments should include assessing for unhealthy substance use, given it can impact ongoing cognition. We recommend using a non-stigmatized approach to focus on how both substance use and co-occurring mental health disorders affect someone's overall health. We recommend educating all patients and caregivers about unhealthy substance use, and medication treatment and harm reduction should be offered to all people who have a substance use disorder and cognitive impairment. So now there's also some references for people to look at later, and I'm going to turn it over to Dr. Chodos to open it up for questions and talk about next steps.
Yeah, thank you so much. And Dr. Defries, are you able to come back on? I just want to remind everybody, we put our emails up here. We always welcome follow-up questions, and we will circulate the slides. The video will be available. And we always want, for now, to plug our warm line, something you can just take a quick look at while we start to get to some of the questions. First of all, thank you. That was an incredible presentation and a lot of information, but done in a way that was incredibly digestible. I love the role play. It was super helpful to hear how you would really apply what you're talking about with a real patient. One of my questions for you guys just right out of the gate has to do with from the questions from the audience, and both were about cannabis and THC, one of the active cannabinoids. One question was the effect of THC on cognition in general, if either of you know, can speak briefly to that. And the other would be, what about the effect of cannabis use and other and cognitive issues in general, and co-occurring other substances? Like, I think cannabis has generally a pretty benign reputation. And so how should we be thinking about and talking to older adults about it?
That's such a good question, because we know older adults are trying cannabis more often these days, and we are seeing kind of increased complications of that. In the acute setting, when someone uses cannabis, THC is the psychoactive component. That's what makes people feel intoxicated. It does impact memory, attention, concentration. Usually those symptoms go away as someone's not intoxicated. The more frequently someone's using it, the more they can have residual symptoms. And we have seen some of the symptoms in cognition linger. There isn't conclusive evidence if it causes dementia or will result in dementia with chronic use. However, we do think, some people may be at risk of dementia, and this could worsen that risk over time. But we definitely know that in the acute setting, THC and cannabis affects cognition and attention, memory, concentration, and that higher THC content and more frequent use, like daily use of high THC, can impact those more substantially. And then you had a second question about with THC involved there, was how would you approach it in the setting of other substance use, I believe, was that the question?
Yeah, and so the actual question was, is there any data on how much more or less severe the effects are for someone using cannabis? And I think at the time, I'm actually trying to remember what the co-occurring use was, but I think the point that people are often co-use cannabis products with other substances.
Totally. I think I agree. It is viewed as a more benign substance, especially now that it's legal. However, we know alcohol is also legal and actually can be one of the most toxic substances. And so I think taking that kind of legality out of the component, but it's more about thinking about approaching safety in the moment, and focused on how you manage someone who's using it acutely in the moment. And so certainly, I think a lot about opioids. Overdose is a really severe thing that I think about. We often focus on opioids when someone's using cannabis, but it depends on the person's goals. And I usually talk about all substances and focus on how it's impacting that person's either overall health or brain health. And so if you're talking with someone who is worried about their memory, certainly talking about cannabis in addition to other substances is important. Can't do it all in one visit. And sometimes you do need to kind of triage what's the most important due to acute safety concerns. But I certainly do bring it up with people who are having changes in memory and our older adults too.
Yeah, and I just add the set of harm reduction principles that Dr. Soran walked us through earlier can be applied to any substance, and they can be applied to cannabis too. So really talking to people about not just do you use it, but how do you use it, and understanding what is the setting that they're in when they use it. So it might be safer to use it around other people. It's safer to go low and slow. So starting with the lowest doses that you can use to see how your body reacts to it. it's safer to think about like formulations of cannabis, which actually come in, many shapes and forms and flavors now. So something like a topical CBD preparation might be something that an older adult who's using cannabis for chronic pain, for example, might be really interested in trying and would have less harm than a high THC formulation that they would smoke. So talking about how they're using is really how to get at that. And then, involving just some education, universal education about what we see, which is we know that more older adults are presenting to ERs, for example, from taking too much cannabis by accident. And a lot of people just haven't had that education, and nor have their caregivers. And once you approach it from a universal education standpoint, it's immediately, it's non-stigmatizing, and it's a good entryway into the conversation.
Yeah, thank you for that. I'll plug also, I know there is a review or a podcast on the GeriPal, so GeriPal, GeriPal podcast, I think did a conversation on what we know and how much we don't know about cannabinoids in older adults, and how the low and slow harm reduction is a lot of what came out of that conversation. So, but I think there's a longer treatment of that as well on that resource. Well, great. I think that was most of the questions, and I'm kind of thinking now we should probably have a webinar on cannabinoids and various, there's so many compounds, but their impacts on cognition. But one thing I was thinking about is, I think an approach in primary care when we see an older person who may be struggling with self-management, and we're doing a cognitive workup to kind of assess for that, and just how to fit in the routine substance use screen. But sometimes when we see people in the community really struggling, we often involve other resources like adult protective services and things like that. And I'm wondering if in your work, working with folks with substance use disorders, if there's, I don't know, an approach that you have when you feel like the substance use in particular is really driving self-neglect or self-harm. If you find that, like, asking for assistance from, like, again, other resources in the community is a help, or how, if you approach that any differently.
I think it's a really good question and has a lot of components to it. I think how I approach it in primary care is really starting out with doing a brief assessment and starting a conversation before I can jump into kind of some of those, thinking about self-harm, how much is their safety at risk. And if there really is imminent safety concerns, I do think about involving, social workers and case managers and the caregiver to think about, do we need to involve adult protective services? But I'd say the first step is really have a conversation, try to get a little bit of more information about their substance use, and then go from there assessing safety risks.
Thank you. And I see that one participant raised their hand. You can also put the question in the chat or the Q&A. Thank you, Triveni. We're showing the CME information. If people want to claim CME, we want to make sure you get that. And there's also information in the chat about that. I think it might be the next slide. There's just like a little bit of information about CME. Yeah, I think, there's, when people have just harmful levels of use, and it's harder to not very interested in managing that. And we're also working on the fact that, or working with the fact that there's cognitive changes, and, sometimes at the level of dementia with a lot of functional impairment. Sometimes I find it hard to get my hands around really managing the substance use disorder. So I really appreciate the, just this framework to help, like, make sure we're addressing, getting the information we can get, contextualizing it, working with that person on whatever their goals are, and continuing to offer them resources.
Yeah. And I found also just talking a little bit more about harm reduction kind of normalizes their drug use and makes it so they don't feel like they have to hide it. And then, offering treatment, never forcing it on someone because they may want it at some point or be willing to try it. And then all the things you're going to do with your brain health plan just become increasingly more important for someone who's using substances. And so there really is a lot you can do, and it'll be done over time, can't be all done in one visit. And just starting that conversation is kind of step one.
Guys, thank you so much. Once again, I learned so much from you. I'm just always so grateful to have you as colleagues. I'm glad that you were available to share your expertise and help our colleagues out there working with folks in primary care. And thank you everybody for joining our webinar today. And we look forward to seeing you at the next one. Have a great afternoon, everyone.